As Chooks introduced earlier today, we'll be talking about a rare medical condition. Now, the first time I came in contact with it, I actually lost a friend to it. We didn't know what was going on. Her body was acting up, and eventually she died. I've lost another friend to it also, and incidentally, that one was a doctor. Today, we have Dr. Folake Kofo-Idowu talking about systemic lupus erythematosus. And for this interview, we'll keep it short. SLE or lupus. Good morning, Folake.
Good morning.
It's wonderful to have you on.
Thank you.
Okay, now, to the business of the day. SLE is an autoimmune disease.
Yes.
Apart from that, what else is it?
It basically is an autoimmune disease, but it's peculiar because it's systemic. It's not restricted to one part of the body.
Systemic?
Just as the name depicts, systemic lupus erythematosus. So it's throughout the whole body. Every part of the body affects every part of the body.
Okay, now, then we go through what SLE is again. Systemic lupus erythematosus, and that is SLE. All right, now, SLE as an autoimmune disease, what is the cause?
The specific cause is not known, but there are certain predisposing factors that have been attributed or associated with the disease or development of the disease over time. Okay. Part of this is hereditary factors. Persons who are related tend to have a higher chance. Say, identical twins. If I have an identical twin, my identical twin has a 25% chance of developing the disease, more than a non-identical twin.
Okay.
Then also first-degree relatives, meaning a person who is directly related to either the mother, father, brother, or sisters, also have 8-fold more chance of developing it than someone who is not related to me. So hereditary has something to do with it. Also genetic factors, certain gene changes have been attributed to it. Also, there's this...
what causes these gene changes?
It ranges from a number of things. Some of these gene changes are passed down. My mom could have it and she just passes it down. She may not have the disease. I may have it. I may pass it down to my children and they may have it. So, and radioactive materials, say exposure to X-rays and things like that.
That seems to cause a lot of
yes, it does cause a lot of damage. And also infections, viral infections are known. A particular viral infection called Epstein-Barr virus, a recurrence of that infection. Usually when you have it, you may or may not be ill, and then it goes down. It's in your body, but it's not active. So if you have recurrence of it, it predisposes the person to developing lupus.
Okay, that virus you talked about, how do you get it? How do people get it?
It's can't even place it now, but I think it's infectious. It's basically infectious. Okay. Can be gotten through blood infection.
Okay. All right, now we know that it's also predominant in certain classes of people.
Yes.
Can you tell us that?
SLE has been found to be more common in females than males. Of every 10 persons, 9 of them, of every 10 people with SLE, 9 of them would be females. So a ratio of 9 to 1.
Any particular reason why?
Probably, I think I could place it on hormonal factors, because these hormones, feminine hormones, also tend to change the progress and the way the disease presents. Okay. Then it's also found in certain age groups. It's described as a post-pubertal. Puberty is when your hormones are raging. So post-puberty, you find a peak of this incidence of this disease. You can find in people as young as 10 and people as old as 50, but the peak age range of discovering the disease is between 15 and 35 years old. Okay,
and of course, black people and Asians.
Yes, in terms of race, it's more common in blacks and blacks, Asians, Afro-Caribbeans also, okay. Much less in Caucasians.
All right, can it be drug-induced?
Yes, it can be drug-induced. Talking about drug-induced, lupus actually is a class, and SLE, the systemic form, is a form of lupus. There can also be drug-induced lupus erythematosus. And it can happen with prolonged use of certain drugs like isoniazid, which is used in treatment of tuberculosis, and procainamide is used in heart disease.
All right, now, lupus, we know that, explain the stages, first of all. As an autoimmune disease, it's something about your antibodies.
Yes.
Fighting your body organs, something of that sort. Could you expatiate on that and explain the process, how it grows?
Okay. SLE is described or defined as a chronic. Chronic meaning it lasts longer than 6 months. Chronic autoimmune. The autoimmune part means it has to do with your immunity, and the auto word just means self. So you have a disease where your body is attacking itself. Basically, that's just it. So you have it's a chronic autoimmune systemic disease. Now, your body doesn't just wake up one day and just decide to kill itself, but something triggers it. And research has shown that it can be attributed to improper removal of dead tissues. Say I have an injury and it's not properly cleared from my system. So the body just sees it. This is not supposed to be here. It tries to take it away. While it's trying to take it away, it sees it as, oh, this seems foreign. And it produces something against it, like, we have to get rid of this before it destroys it. It's just your body's trying to protect you, but it overdoes it. And then they produce antibodies, what we call antibodies. These antibodies seek, invade, and destroy foreign bodies. So you produce antibodies against your own cell. Do you understand? You produce it against your own cell. And these parts of the cell that they detect are usually things that have to do with the nucleus, which is the core of a cell, and the fluid that surrounds or that bathes the nucleus. And you have nuclei in almost, except for red blood cells, you have the nucleus in every cell in the body. So that's why SLE is really bad. So you produce these antibodies and it just goes round and your body starts producing it. In terms of stages, you can have phases of remission where it's there, you have the disease, but you're not really symptomatic. You just have the mild general complaints, and then you can have episodes of flare-ups, which can be brought on by certain conditions like using drugs, pregnancy, hormones, and also using hormone replacement therapy.
Okay. All right, now, you know what? Right now we're going to open the phone lines. The number will be scrolled across the screen in a bit. If you have any questions or contributions, you can call in and ask or contribute. Also, you know what? One of the symptoms that, because I had a friend who had SLE several years ago, and then we noticed a rash on her face. We'd asked, and we're like, she said it was measles, and we're like, okay, but it's only on your face, right? And she says, yeah, that's what the doctor says. How could you mistake a rash like that for, because we know it's in one region, how could you mistake a rash like that for measles? Because it's one of the symptoms.
Personally, I don't know how you can mistake such a rash, but for whatever reason, I can't say much about that situation. But what I can say is that rash is peculiar. About 50%, 30 to 50% of people who have lupus would have this rash.
Okay, let's take a call from Yinka from Ebutemeta. Hello, Yinka, good morning. Hello? Yinka, please speak up.
Hello?
Yeah, good morning.
Good morning. Yeah, I just want to find out, because on the screen, we can see that it's only Caucasians that we see the manifestation of this lupus on. Okay, how do we know when a black person gets it? What are the symptoms?
What are the symptoms she's asking for this?
Okay.
For a black person. At this point, you will say the symptoms are the same, no matter even if you're black, Caucasian, or whatever.
Yes, they are.
Yes. Okay.
But lupus is a quite remarkable disease in terms that no two patients are alike. Yes, you have, because it's a wide range of spectrum of symptoms, you can have from the brain to the heart to the eyes, the lungs, intestines, your kidneys, joints, muscles. So I could have predominantly joint manifestations. Someone else could have predominantly skin manifestations. And these manifestations also vary in degrees. So you have, for general presentation, patient complains of fever, low, they call it a low-grade fever. It's not very high, like malaria. It's not very high, but you just know, I'm just warm. You keep telling yourself, somebody touches you and goes like, oh, you're warm. You're like, yes, but it's something people can really knock off easily. So fever, low-grade fever, you can have hair loss, you can have headaches, you can have joint pains, and a number of other things like that. Then also there are some presentations that are specific to systems. For example, if you start from the head, like I said, you can have hair loss and skin changes.
Rheumatoid arthritis.
No, rheumatoid arthritis is different. It's also an autoimmune disease, but it's different.
It's not one of the diseases that lupus attacks you with, is it?
No.
Okay.
It's not. It's different.
Okay.
And you can have in the brain, you can have cerebritis. It's an inflammation of the brain cells. They can present with headaches, which is the most common presentation.
Is there a cure?
Is there a cure for SLE? No.
How do you control it? How do you manage it?
Management of it is by controlling the symptoms, what the patient presents with, you treat that. And also the empirical, in terms of basic thing, because it's an immune problem, you try to hit the immune system directly by suppressing it with steroids and cytotoxic drugs.
What's the lifespan of somebody who is suffering from the SLE?
Now, with early discovery and good treatment, about 90% of patients have a 10-year survival rate. So in 10 years, 90 of 100 will survive with good treatment.
Okay, now, could it lead to other conditions? The SLE is the final bus stop, is it?
SLE is a final bus stop, but
the symptoms are ranging from...
The symptoms range. You can have kidney problems, you can have heart problems, brain problems. They can have frank psychosis. You got to see the person and act mad.
Okay, we have a caller from Jos. George, good morning.
Yeah, hello.
Hello, George. Good morning. Hello, speak up, please. Oh, we lost that. Okay. Now I know somebody. I've heard of somebody else who has lupus but flies out regularly to get treated. Now, is it that we cannot manage it here?
You can, because basically you're using drugs. Like I said, you manage the symptoms. Say you have joint pains, they give you anti-inflammatory drugs, ranging from, it has a range, to suppress the pain and the inflammation. You have heart problems, they can try to sort that out.
We have Rachel from Jos. Hello, Rachel. Good morning. Rachel?
Hello?
Hello, good morning.
Hello?
Yes, please speak up, Rachel. Okay, we lost that one again. Okay, now, the SLE does have some similarities to HIV/AIDS.
Yes,
in the sense that it doesn't have a cure, right?
In terms that it doesn't have a cure and some of its presentations.
Okay.
And complications.
What are the similarities? What are the similarities and differences? Can SLE lead to AIDS, or is there any connection? Is it related?
They are not particularly related, other than they both affect the immune system, but in different ways. One suppresses the immune system, the other one makes it overactive. And in terms of the presentation, you can have HIV-induced kidney problems. It's called HIV nephropathy. You can also have nephritis, which is a kidney problem from SLE. You can also have HIV-induced neuropathy, which could range from stroke, one arm, the whole body, different feelings in the body. And then SLE also can give you pictures like that. Also, SLE, patients with SLE they have a predisposition of developing certain cancers of the blood, say non-Hodgkin's lymphoma and also lung cancer. HIV also predisposes certain patients to developing some cancers, though they vary. So basically, those are the similarities.
Okay, now, do we see, there are some things that I hear that SLE patients shouldn't take. I hear that since their body doesn't function as other people's, let me hold that question. We have a caller from Port Harcourt, Kito. Hello, Kito, good morning. Hello, speak up, we can hear you. Kito.
Yeah, good morning.
Good morning. Please, okay, we lost that again. That's an unfortunate one. I hear that since your body cannot process stuff like normal people or like healthier people, you know, there are certain precautions you should take if you're living with SLE. The intake of the food, kind of food you eat, and then going on and so on. Tell us a bit more about that.
Well, yes, they have certain predispositions. Patients with SLE are advised to rest well, rest good, and because they present also with easy tiredness, they get tired easily for long periods of time. So they're advised to rest a lot. And also you're advised to eat good food, balanced diet, nutritious food. And based on presentation, because it can also, of the different parts of the body, it can affect, especially the kidneys, you're advised to have a low salt diet, low cholesterol diet, and also because they are predisposed to having vasculitis, which is an inflammation of the blood vessels, and these persons have a higher predisposition of developing coronary artery disease, which is a blockage of the vessels that supply the heart. And if those things go blocked, the heart muscle dies and person develops a heart problem. So they're advised to eat healthy, just like any other person. Also, exercise helps a lot, about 30 minutes of exercise every day.
For someone who's weak?
Yes. It doesn't have to be vigorous exercise, and it doesn't have to be at a stretch. 30 minutes exercise broken down at different times of the day. So you could do 10 minutes every 6 hours and just make it about 30 minutes in a day. Also, they are very sensitive to sunlight, ultraviolet rays of the sunlight. So they're advised to use use SPF, minimum of SPF 15, and to use it all over the body. Wear protective clothing. There are some clothing that come with sun protection formula. So they're advised to really protect themselves against ultraviolet rays.
Okay, we have Florence from Port Harcourt. Hello. Hello, Florence. Hello, good morning, Florence. Could you speak up, please?
Hello.
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 Yeah?
Hello.
Please, could you speak up? I can hear you. Continue, please.
Hello.
Yes, I can hear you. Okay, maybe when you get to it, you should just ask the questions. All right, doctor, thank you for coming on. It's been a good chat with you.
Thank you
very insightful. But, you know, maybe I should ask one more question.
Okay.
Now, if it's in your, it's in your family, you're trying to avoid it, are there any steps you take to avoid?
Try.
Yes.
To avoid it. Not really. There really aren't, because you don't even know if you would have it. I may have a twin and she probably may not have it. She has a 75% chance of not having it. So there really isn't anything in particular you do not to have it. But be careful, indiscriminate use of drugs also, because drugs can also precipitate it. And also people who, for instance, people who work in mercury factories and silicone use. I don't mean to be partial, but if my twin sister has it, I think it would be unwise of me to have silicone breast implants.
Wow.
Or to go and work in a mercury factory.
Okay.
So you would tend to things that may precipitate indiscriminate use of drugs, like I said. And sometimes some people may just be unfortunate, you know, they have a predisposition and the person has tuberculosis and has to use the drugs. But then if you inform your doctor that, oh, because they ask you about family history of diseases and all, and if you give that history up, they should be able to find something better to give you.
All right, thank you, Dr. Folake, for coming on. It's been a good chat.
Nice to be here.
The show continues after this break.